Thanks, Marty. Good afternoon, everybody. It's really a great opportunity to be joining you this afternoon. For decades, preterm feeding practices were actually based on just expert opinion and a few observational studies. And this was really because there was not a lot of scientific literature. There was hardly a body of literature to guide practices. The thing is, these practices, based on old beliefs, have actually carried through to many neonatal units even today. And so the goal of today in this presentation is to actually uproot some of those old beliefs by looking at the latest science with the aim to build some standard feeding protocols for our units. So this is just an outline of what my talk is going to be. We're going to look at the importance of feeding protocols and then some elements that you would want to look at when making your own standardized feeding protocols, which we'll go through in the presentation. So when it comes to nutrition in our preterm babies, it is actually really important because they have very high nutritional needs, especially in comparison to their term counterparts at the same postnatal age. And adequate nutrition is crucial for growth and neurodevelopment in the third trimester. If there are deficits with nutrition, then it results in extrauterine growth restriction. And this is closely linked to a high risk of poor neurodevelopmental outcomes. Preterm infants are at risk of nutritional deficits due to their gut immaturity, the fact that they have underdeveloped suck-swallow reflexes, and then often because they're born preterm, the moms actually still have a very low milk supply, or resulting in potential deficits. Just kind of move it. Seems to have frozen a little bit. All right, so the goals of preterm feeding is to provide the correct nutrition to achieve growth rates that of a fetus of the same postmenstrual age would achieve, and to maintain normal concentrations of blood and tissue nutrients while ensuring satisfactory functional development. To assist clinicians in achieving these goals, several guidelines are available for preterm infant nutrition and feeding. But it's important to remember that nutritional requirements are unique for each individual, owing to diverse pathophysiology, metabolic needs, as well as neuroendocrine regulation. And so when caring for these infants, one must recognize the need for individualization and changing pathophysiology, especially when designing feeding protocols. Standardization of a feeding protocol has been identified as an important approach for improving the quality of care and reducing unnecessary variations in nutritional practices within the NICU. Often when these old beliefs and practices are carried through without standardization of feeding protocols, we actually disadvantage many of our little preterm babies. Elements that we can look at in order to design our own feeding protocols are what should we be feeding, how to feed, when to initiate and when to progress enteral feeds, when to fortify human milk, and then how to evaluate for various signs of feeding intolerance, as well as when to withhold enteral feeds. In addition to that would be the whole section on monitoring the growth of babies. So when some of these or all of these elements are part of a standardized feeding protocol, it is shown to improve clinical outcomes. Things that have been improved include a shorter time on parenteral nutrition, a shorter time to transition to full oral feeding, a shorter length of hospital stay, improved postnatal growth, and an actual reduction in the incidence of NEC. So what I wanted to do today is actually look at each of these elements that will form our standardized feeding protocols. And then we'll look at the science behind each element. And while we do that, in your own mind, start to think how you would make a standardized feeding protocol. So we'll start by looking at what to feed. And here it is quite simple. Breast is best. It was an opinion in terms of an old belief, but this is one thing that science has really proved true. And the World Health Organization, together with other expert groups, recommends that mom's own milk should be the first feeding choice for all preterm infants. And together with all the benefits of breast milk, there is actually strong evidence that feeding mom's own milk to preterm infants, exclusively or in combination with other milk, as opposed to only infant formula feeding, is associated with a reduced incidence of NAC. And this is one of the things that really does reduce the incidence of NAC, and that which is breast milk. Sometimes, though, mom's own milk is unavailable or too little. And so then the second option would be to use donor human milk as something that you can supplement mom's own milk with, or you could feed the babies exclusively with donor milk. Evidence from a Cochrane review indicated that preterm infants with donor human milk alone, or in combination with mom's own milk, rather than infant formula, also reduced the incidence of NEC and feeding intolerance. The one disadvantage about donor human milk is that studies have shown that there is slower growth rates during the in-hospital period, but evidence on long-term growth outcomes are actually limited. So that would be the second option then in terms of feeding. And when either of those options is not available, one would move on to a formula feed. And I haven't covered it in this presentation today, but it's important to look at the constituents of each formula in terms of deciding which formula you would use for your preterm babies. Under the element of what to feed, when looking at feeding protocols, there are a few other things that I haven't covered, but there are two references here on the screen that you can look at in terms of your own reading. They cover these topics quite well. That would be total fluid requirements, how many calories do our babies need, and then also macro and micronutrient contents of the feeds. So if we move on now to our second element of our feeding protocol, that would be how to feed. So the establishment of safe oral feeding in preterm infants may be delayed because of poor coordination of sucking, swallowing, and breathing, particularly in those infants less than 32 weeks gestation. So preterm infants can then receive nutrition through an orogastric or nasogastric tube, and you can use either continuous or intermittent bolus delivery of milk until our infants are capable of fully feeding orally. So we're going to look at what we should be doing, orogastric or nasogastric, and should we do continuous or intermittent. Let's look at what the literature says. So in terms of orogastric and nasogastric tubes, there's a few suggestions that one may have advantages over the other, but there's nothing really, really solid in the literature. Some people prefer nasogastric because of the ease of fixation. It also allows breastfeeding. But the problem with the nasogastric tube is it obstructs the nostrils, and that can increase the work of breathing. So therefore, one would then prefer the orogastric tube where there's no obstruction with to the nostrils. The problem with this is that it's easily displaced There could be local irritation, and it can be a little bit of a hindrance for breastfeeding, but that's more opinion-based. It's not really backed by science. So in terms of the reviews out there looking at these two, probably the biggest one was done in 2013. It was a Cochrane review where they compared the two methods, and they actually found that there was no significant difference in time taken to establish feeding, time taken to establish full oral feeds, time taken to regain birth weight, and there was no difference in weight, velocity, incidence of apnea, desaturation, and bradycardia. And so given the current available evidence, no method is actually recommended for preterm infants in both high income as well as resource limited settings. And so when it comes to how we're going to give our feeds via orogastric or nasogastric tubes, it's really up to the healthcare providers to use whatever method they prefer. But the thing here would be that the protocol is standardized for your unit. So what you use for one baby, you would use for the next. Then just moving on to bolus or continuous feeds. Just a little bit about the advantages. Bolus feeds promote cyclical release of gastrointestinal tract hormones to stimulate gut maturation and motility. And it also increases splanchnic perfusion more than continuous feeding. Energy expenditure may, however, increase using bolus feeding compared to continuous feeds. And when looking at the systematic reviews, there's a little, but it's weak evidence that does show that continuous feeds, when using continuous feeds, there's a longer time to reach full enteral feeding compared to intermittent feeding. But there weren't actually any other significant effects on other variables when looking at these studies. So intermittent bolus feeding may be more beneficial for low birth weight infants, but this is really just because of that one study that found that they reach full feeds quicker. And so like Cochrane usually does, the meta-analysis on this actually suggested that a lot more studies need to be done to determine the most appropriate feeding method. And so once again, what you decide to use must just be standardized in your feeding protocol. And when you decide, if you're going to decide to switch between the method for certain patients, there should be a protocol looking at why and when to do that. So the elements not covered under this section would be transitioning to oral feeds, scheduled versus responsive feeding, and then TPN, when to start it, when to stop it, if you're going to use it at all, because you always need to weigh up the risk-benefit ratio. And so those studies that are referenced at the end, once again, cover these sections quite nicely. So when we move on to the practice of achieving full enteral nutrition, this is where these old beliefs have really been carried through. And so we're going to look at early versus delayed initiation of feeds, slow versus fast progression, and then early full enteral feeds. Establishing full enteral nutrition in critical ill preterm infants can be challenging, and the ultimate goal is to achieve a balance of optimizing nutrition to achieve postnatal growth while avoiding feeding intolerance and NEC. Small volumes, a delay in starting, and slow advancement has been the practice of many neonatal units, but this was based on beliefs from expert opinions and observational studies where they felt that these methods prevented NEC. So when we look at each component of this section, when we look at early versus late initiation of feeds, early feeding is defined as initiating feeds in the first 72 hours, but ideally actually in the first few hours of life. Studies report a starting volume of between 5 and 25 mils per kg per day. And this meta-analysis referenced below on this slide, it was actually only 2 of the studies that were above 20 mils per kg per day. We found in this scientific body of literature now that there's no increased risk of NEC when compared to delayed initiation of feeds when we actually do early initiation. And in fact, early feeding is associated with lower sepsis rates. Mortality and time to regain birth rate is decreased in early feeding groups. And so when looking at the evidence, it actually supports early enteral feeding and now discourages fasting, even in critically ill neonates requiring inotropes and umbilical lines, which is quite different from those traditional old beliefs. When we look at slow versus fast progression, so slow would be starting feeds at about 15 to 24 mils per kg per day, and then increasing feeds each day until reaching full feeds by that amount. Whereas fast would be starting at a certain rate, but then increasing between 30 to 40 mils per kg per day until reaching full enteral feeds. In 2021, there was a Cochrane meta-analysis, and here there was no difference in the risk of NEC between the 2 groups. And even when they looked at high-risk groups like extremely low birth weights, intrauterine growth restriction, and babies with a PDA, there was actually no difference. There was increased risk of feeding intolerance actually with the slower rates, a longer length of stay with slower rates, difference in survival or severe to moderate neurodisability. But one study reported that there was an increased risk of cerebral palsy in the faster rate group. So based on all of that, because there seem to be more benefits of fast progression, it's now encouraged that we start soon and build up fast. So if we're going to build up so fast and start so soon, what about actually just starting full feeds straight away? So here in 2020, there was a review that looked at 6 randomized controlled trials, and that included a total of 526 infants. So it was relatively small. Here they included early full enteral feeding as volumes of between 60 to 80 mils per kg per day, beginning soon after birth. Control groups were given early progressive enteral feeds with advances in volumes of between 20 and 30 mils per kg per day until full enteral feeds were achieved. What's important to note here is all these trials were conducted in resource-limited settings. And so when we're looking at the group where they were progressively increasing the feeds, those babies were put on IV fluids. They did not receive TPN in terms of their management while waiting to be on full enteral feeds. And then the one thing about this study is they didn't really include extremely low birth weight infants. It was babies over 1 kilogram that were included in the studies. What they found was that early full enteral feeds were actually associated with higher weight Z scores at discharge. The early full enteral feed group regained birth weight faster. There was no difference in the rate of feeding intolerance or NEC. There was no difference in sepsis or mortality rates. And full enteral feeding groups had shorter hospital stays with an average difference of about 3 days. And so in conclusion, because it was such a small study and only done in one country, the recommendation is that we still need a lot more randomized control trials to be done before adopting this practice. However, it looks very, very promising in terms of a future directive. Then moving on to fortification of feeds. So yes, human milk is by far the best, and it is the first choice for nutrition, but the density of both macro and micronutrients is actually inadequate to assure optimal development if it is not fortified. So the goal when actually using fortification is to raise the concentration of nutrients so that the recommended feeding volumes of between 160 and 180 mils per kilogram per day in preterm infants receive quantities of all the nutrients that fulfill the needs. There's two ways that fortification can be done. The first would be standard fortification. This is where we assume that human milk is not adequate to ensure optimal delivery of the nutrients. And so all preterm babies are given a standard fortification to their feeds. The other method is individualized fortification. And this can be either adjustable, where one monitors the urea nitrogen levels in the preterm baby, and then based on that, you would then adjust the amount of fortification that you are doing for that baby. The other way is targeted, and here you would analyze the milk content, and based on the shortfall of nutrients, you would then add that as fortification. Both those methods are quite costly, and so in resource-limited settings, often the standard fortification is what we use. It's not clear which subpopulations of preterm infants benefit the most, or whether all very preterm infants should receive fortification routinely. And there's also no consensus on the best time to start mom's own milk or donor human milk fortification. But guidelines typically add fortifiers when we have reached 100 mils per kg of enteral feeds, or when the full enteral feeding has been achieved, and that is between 150 to 160 up to 180. The new introduction of exclusive human milk fortifiers allows exclusive human milk feeds. And so this is when you're worried about the fact that you're not exclusively breastfeeding anymore by adding fortifiers, which are mainly like formula-based products. This new human milk fortifier would take away that issue, but they're not yet available in South Africa. Hopefully will be in the near future. So all of this is really to prevent feeding intolerance in NEC. So what are the definitions of feeding intolerance? That is something that varies very widely, with no real consensus. But generally, feeding intolerance refers to the inability to digest enteral feeds with higher gastric residual volumes. Feeding intolerance is commonly thought to be a symptom of NEC. However, up to 50% of preterm infants experience feeding intolerance during the transition to full enteral feeding, and certainly not all of them have NEC. Dysmotility is the most common cause of feeding intolerance, and other causes include reduced gastric acidity, as well as the inactivation of the enzyme pepsin that digests protein-containing milk. So when a baby has what we think is feeding intolerance, routine abdominal x-rays actually have very limited value in assessing if this intolerance is an early symptom of NEC. And until the validity of other methods is established, feeding intolerance alone should not be considered a risk factor for NEC. And progression of enteral feed should not stop unless associated with other sinister clinical signs and symptoms of NEC. Just looking at enteral feeding and NEC. So babies with, well, enteral feeding occurs in 90% of infants with NEC, but that does not mean that enteral feeding explains 90% of all NEC cases. High exposure to enteral feeding is also observed in infants who actually never develop NEC. And defining the causes of NEC requires a new framework around the principle of multi-causality, which is a whole nother talk on its own. And then just to remember that spontaneous intestinal perforation and NEC are not the same, and enteral feeding has not been implicated as a cause of spontaneous intestinal perforation. So just in summary, if we look at the key points in terms of trying to make our standardized feeding protocols based on the science now, we know that breast is best. The use of fortification allows achievement of optimal nutrition. Feeding intolerance, defined by increased gastric residual volume, is not closely associated with NEC, and unless with other sinister signs, should not delay feed progression. Early initiation, faster progression, and possibly even early full enteral feeding does not increase the risk of NEC as suggested by latest literature. And then the high prevalence of NEC is actually unexplained by feeding interventions, and there is a need to investigate the pathogenesis of NEC further. There is now sufficient data from multi-center randomized trials to shift beliefs and standardize nutritional practices that will improve growth without increasing short-term risks. Definitely more trials are needed regarding long-term outcomes. However, currently there's no evidence to direct any protocol and should not prevent a shift in practice to support the evidence that is available on short-term outcomes. And then just a final word, caution must be taken in our little babies, less than 1,000 grams, those with congenital disorders, as well as birth asphyxia, as these patients were actually mostly excluded in the studies that we have presented today. And then that is just a slide with my main references. And that brings us to the end of the presentation. Thank you.
Thank you, Dr. Trudy Martin, for your amazing talk. You covered a lot in those first few slides. So we'd like to invite our next guest, who is Dr. Nxumalo. You may start sharing your presentation, MQ. Thank you. For those of you who have questions for Dr. Martin, please start posting it in the Q&A tab and not in the chat group, and we'll try and get to your questions at the end of the webinar. Thank you.
Good evening, everyone. Sorry, my mic wasn't on. So this afternoon, I'll be presenting on the supplements and micronutrients that we use in preterm infants. So I won't go too much into the preterm nutritional challenges because Trudy has actually covered it quite a lot. So these babies do miss out from that third trimester where they actually get most of their minerals and micronutrients. And with their increased rapid growth, they're at high risk of micronutrient deficiency. The vitamins and micronutrients that I'll be covering today are just iron, vitamin D, zinc, calcium, and phosphorus. These are the ones with the widest evidence base. So starting with iron. So iron has hematological effects. It increases the hemoglobin, with the earliest effects being seen by 8 weeks, but the significant effects continue, and there's a greater HB in supplemented babies at 6 to 12 months as well. It improves your iron stores, therefore decreasing the incidence of iron deficiency anemia. And in the hospital, it's associated with a reduced need for blood transfusion, about a 30% reduction. And so far, there's no evidence of any adverse outcomes from supplementation. So iron has mostly been studied for its hematological effects because we're trying to prevent anemia of prematurity. But there are newer studies that are looking at how it affects growth and neurodevelopment. So in terms of growth, there's been evidence for a modest increase in linear growth, not necessarily weight gain. And this effect was found mostly in human-fed infants, but this is of low quality level evidence. In terms of neurodevelopment, most randomized controlled trials and systematic reviews have found no significant improvements in cognitive or motor outcomes with iron supplementation. There is, however, a recent Swedish randomized control trial that looked at early versus late supplementation. And by late supplementation, they started the babies on iron after day 61 of life, which is quite late. When they followed these babies up at 3 months, they were shown to have an increased prevalence of behavioral problems and externalizing behaviors. And they also had an increased incidence of abnormal neurological examinations. So this just further supports early iron supplementation. In terms of the recommendations on how much to give, by WHO, I mean the World Health Organization, and SAPA is the European Society for Pediatrics, Gastroenterology, Hepatology, and Nutrition. The recommendations are related to elemental iron, and that's important because different formulations of iron have varying amounts of elemental iron per mil. The WHO recommends 2 to 4 milligrams per kg per day, while SAPA recommends 2 to 3 milligrams per kg per day. Both societies agree to start at 2 to 4 weeks of age and to continue supplementation at least until 6 to 12 months of corrected gestational age. The commercially available supplements are iron drops and iron syrup. And as I said, these have varying amounts of elemental iron, so you actually have to check how much you're giving. There is also a bit of iron in multi-component human milk fortifier, but these are small doses and done intentionally to allow for tailored supplementation. In terms of vitamin D, so vitamin D enhances the absorption of calcium and phosphorus. Its effects on growth, it improves weight for age and height for age Z scores, but it has little to no effect on head circumference. Its biggest base of evidence is on its effects on bone mineralization, with an improved biochemical vitamin D status in supplemented infants, as well as a reduced incidence of deficiency. And then in very low birth weight infants, it's been shown to reduce the risk of metabolic bone disease as well. So far, there are little to no effects on neurodevelopment. Neither are there any effects on mortality or morbidity outcomes. The recommendations, so the WHO recommends 400 international units to 1,000 international units a day until the babies are 6 months old. SAPA has a similar range of 400 to 700 with a maximum of 1,000 international units. The commercially available supplements, the multivitamin drops that we all commonly use, all have at least 400 international units of vitamin D, in each drop. Multi-component human milk fortifiers also have a bit of vitamin D in them. It's around 40 international units per gram. So if you calculate it out, that comes to around 480 international units a day. So if you give these in combination with multivitamin drops, we actually land on the upper end of the scale, around 880 international units. Zinc supplementation is still more experimental at this stage, so there's fewer randomized control trials on this one. It is a trace element that's involved in numerous physiological processes, including enzyme function, gene transcription, and cell signaling. And there's low concentrations of it in human milk, which tend to decline over time. The evidence for its use comes from a 2022 Cochrane review that reviewed 14 randomized controlled trials. They found that with low quality level evidence, there were modest improvements in weight gain and linear growth. Again, little to no effects on head circumference. Of note, there's little to no effects on sepsis or mortality, which is not what's been found in the pediatric studies. And there's at this stage a lack of data and inconclusive results with regards to its effects on neurodevelopment. ESPGHAN recommends an enteral intake of around 2 to 3 milligrams per kg per day. At this stage, the WHO does not recommend supplementation as there's insufficient evidence. You can give zinc using zinc syrup, which is around 10 milligrams per 5 mils. And there's also zinc in multi-component human milk fortifier. The ones that we currently use, if you calculate it out, you actually end up giving 2.88 milligrams.
Oh dear, I think we have lost MQ briefly there. Let's just see if he'll be able to join, but maybe we can look at a few of the questions so long and just see if MQ can join us again, because I think he just had a few more slides left to share. So maybe I can ask the one question so long to Trudy. Trudy, are you ready just to answer one of the questions so that we can see if MQ is able to join back in?
Yes, I'm ready.
Okay, that's perfect. So the first one that I want to ask you is, how do you objectively monitor adequacy of nutrition in a PREM? In terms of weight gain might be attributed to just gaining fat, but what about bone health and body composition? So this is quite a difficult one. I don't know if you've got any ideas.
Well, it's definitely the first thing would be your anthropometric measurements, but looking at length, head circumference, as well as just the weight, because that would tell us a little bit more than just fat alone. And then in addition to that, there are some investigations that we can keep an eye on in terms of what's happening, like in terms of electrolytes, minerals, even our liver function, alkaline phosphatase, as well as serum urea and creatinine levels can help give us an idea of what's going on with even the protein constitution of our babies.
Okay, that's great. I don't know if any of the other panelists want to chip in on that. Maybe Shakti, Prof Harrison, do any of you guys have anything else to add that might make it easier for us to know where we are nutritionally with our babies?
Yeah, Trudy's exactly right. We've got anthropometrics cover most things, and then if you've got good bone growth, that's covering a lot of other issues. And then if you are at the Chelsea and Westminster Imperial College, you can do MRI and have a look at all that. But that's far more than what's needed.
Okay, that's good. I'm going to actually ask you, Mike, if you don't mind starting your presentation. I don't see MQ just yet. Maybe we can ask him. Oh, are you back? Oh, so sorry about that.
Sorry about that.
Okay. So Mike, you can stop sharing. You can just finish off. Okay, great. We're glad that you are back. Sorry about that.
Sorry, everyone. I just had a short connection problem.
Okay, great. We can see.
So I think I was talking about zinc.
Yes, that's where.
Sure. Just to say that there is zinc in multi-component human milk fortifier, and the amount of zinc that you actually end up getting is within that recommended range for that ESPGHAN recommends. So typically we are already supplementing. For calcium and phosphorus supplementation, its effects have been studied as a combination. So usually at a ratio of 1.7 to 1.5 is to 1. There has been no significant effects on if giving these supplements alone, but there is evidence that there's increased growth if you give them as part of a multi-component human milk fortifier. That was borne out in a 2017 Cochrane review. There's evidence of its effects on bone mineralization. It reduces the risk of metabolic bone disease, and there is low certainty level evidence that it also reduces osteopenia. So far, there's no evidence on any neurodevelopmental outcomes. The recommendations, the WHO and ESPGHAN also overlap here with the range between 120 to 200 for calcium component and between 60 to 115 for the phosphorus component. And this is exactly what you'll find if you put in your multi-component human milk fortifiers. So you don't have to calculate it out for each baby. And then I'll just speak a little bit about phosphate supplementation. So phosphate is not recommended as a supplement on its own, but it can be given, like I said, as a calcium phosphorus combination. This is because of an increased risk of nephrocalcinosis as well as electrolyte imbalances, particularly hypocalcemia. So it's only indicated in the management of metabolic bone disease. And so that would require serological testing with your ALP and your phosphate, your serum phosphate. And the screening guidelines are unit specific. The commercially available products are a sodium dihydrogen phosphate solution, as well as phosphate effervescent tablets at a recommended dose of 0.5 millimoles per kg per dose, 8 to 12 hourly. And so to conclude, most of the evidence is of low to moderate certainty. There's so far no evidence of adverse effects, which is why we continue to use supplements. There are multiple commercially available products with varying amounts of vitamins and micronutrients, but the ones that we are currently using are adherent to the ESPGHAN and WHO recommendations. But you should check if you are buying a product, what actually is in there. So these are my references, and thank you very much for your patience.
Thank you so much, Mnqobi. That was absolutely great. So that was the second bits of our webinar today, is looking at the supplementation. And I see there's already good questions coming up. Now I'm going to ask Prof Harrison to talk to us about this hype of probiotics and what the evidence is for that. And then we'll get to some questions. Thank you so much.
Hello, can you hear me?
Now we can hear you.
Something, I don't know what's happening here.
You just have to put it in presenter.
Okay.
There it goes. Thank you.
Okay, you can hear me now. Okay, so thank you. I'm going to be talking on probiotics for preterm infants. So probiotics for preterm infants, people were manipulating the guts, reliably informed of babies in the 1960s and 1970s. And they did this because they knew that babies were increased risk of NEC, of late onset sepsis, feeding intolerance, and mortality. And the thinking around this time, which is still relevant today, is that the gut microbiome is immature and is more susceptible to pathogenic bacterial colonizations. And so people were proposing using the probiotics to modulate the gut microbiome, enhance barrier function, and reduce inflammation. And as I say, people were doing this in the 60s and 70s, and in the 90s, they started actually publishing manipulation of microbiome with lactobacillus. And then there is a paper actually from 1999 where in Colombia, South America, where they actually showed a reduction in NEC with lactobacillus. But as always, we need to look at the evidence. So this is the Cochrane latest evidence that they had in 2023. And what I've done is I've capitalized the words they use, because it's very important when you're reading Cochrane, because it's very nuanced. So it says probiotics in VLBW infants may reduce NEC, and they give it's almost 50%, just a bit less, and probably reduce the risk of death, but that's by far less. It's 20%. Probiotics probably have little or no effect on serious infection and may have little or no effect on disability. Again, non-committal. Probiotics may have little or no effect on NEC, death or serious infection in infants less than 28 weeks or less than 1 kilogram at birth. And those are the babies that we're particularly worried about. They're the ones who get NEC. And the standard conclusion, given the low to moderate certainty of evidence for the effects of probiotic supplements, there is a need for further large, high-quality trials. There was a lot of outcry because probiotics falls into two camps, those who believe and those who are still in equipoise or perhaps skeptical. And the believers said that the Cochrane was being swayed by the bigger trials, which had used, and I put in inverted commas, the wrong strains of probiotics, and it wasn't actually teasing out what the correct strains were, and if they used that, they would have shown a far greater effect. So what's the actual meta-analysis on probiotic strains? Well, we've got two, one from 2023, and then they refined it again in 2025 because they found some studies didn't actually fulfill the criteria. The 2023 meta-analysis looking at basically containing Bifidobacterium infantis versus those without, and the B infantis had a much greater reduction in NEC compared to those without, and you can see on those relative risk numbers there too. And then in 2025, they actually broke it down into three different combinations that they used. The lactobacillus on its own had a relative risk of 0.59. Bifidobacterium and lactobacillus was a bit better. You almost got you got a 50%, just over 50% reduction. And when they put Bifido, Lacto, and Streptococcus, those were most effective, but that was only a few studies. And so what people, the believers in this, and a lot of people were pushing, was that multi-strain probiotics appear to be far more beneficial than unistrain, and you've got to have bifidobacteria in there. And actually, as I said earlier, the big studies, particularly in the studies in the UK, a PIP study used a single strain and the wrong strain, if you like. And around this time in 2023, actually a survey was done within the neonatal units in the UK, and I think only about 40% of units routinely were using probiotics just 2-3 years ago. So recently we have something called an umbrella meta-analysis. Yes, I had to look it up too. What it means is a meta-analysis of meta-analyses. And it included 35. And what was amazing to me, that there have already been 35 meta-analyses of probiotics in various guises, whether it's multi-strain, strain against placebo, but there are 35 that were included. And this umbrella meta-analysis showed that probiotics reduced NEC by almost 50%. They reduced overall mortality by close to just above 25%. And the review suggests that probiotics reduced NEC and related mortality together. And the actual, and this was a few months ago, the conclusion from the umbrella meta-analysis that probiotic supplementation should be recognized as preventing NEC in preterm and very preterm infants, particularly those containing multi-strains. So as you see, as we just in the last year or two, the call and the shift has become far more probiotics, if you like. However, there are gaps and there are challenges in all these things. The studies are very heterogeneous. The strains are different, the doses are different, the combinations that have been used are different, the durations, the number needed to treat. I mean, number needed to treat varies between 25 and 50. And the populations that were studied are completely different. Also in the PIP study, I mean, as many of the babies who were on placebo were already colonized with the treatment probiotic, probably because of hygiene is so difficult when babies are in neonatal units for months on end too. There still is low certainty of evidence in extremely preterm ELBWs. People are still worried around that. Which strain is best? And is it 2? Is it 3? Is it a multi-domain? Do you put your bifidobacteria, 2 different ones in together? It's still unclear around that. And also timing, when to start. Some people start on the first day. Some people start on the first week. Some people start on the second week. Some people start with half doses. Some people start with full doses. There's so many different protocols and ideas out there too. And there still are concerns regarding long-term outcomes, neurodevelopmental growth, and more recently, people have been talking about immune modulation that can occur, particularly in a developing infant. And there are safety concerns too. And this completely blew the probiotic story out the water. So in the FDA, which is the Food and Drug Administration in the States, raised concerns about probiotic products sold and used in hospital preterm infants. That was in October 2023. What happened was one infant got septic and actually died, and it was genetically confirmed that the child had died of the probiotic that he'd been administered. And then there were about 2 other dozen adverse events in the USA. And remember, probiotics fall under food. They're not a drug too. And so the FDA issued warning letters to 2 companies for illegally selling probiotics to treat diseases in preterm infants. And there was a complete halt almost in all probiotic use in preterm infants in the USA 2 years ago. And so we've all been waiting to see, well, now you've almost got a real-time incredible situation to monitor what's happening here, because surely you could look at the database. Most of these units on the VON database, you'll be able to look and see what's happened. It's historical controls. It's not, it's not high evidence, but it's still lifetime data that could tell us perhaps what's happening. But nothing's come out yet. And I did a final search yesterday afternoon, and there's an article published less than 48 hours ago. It's the first article that's been published that is looking at what's happened in the States, having had a ban on probiotics, and it's in Journal of Perinatology. As I say, it came out on Monday evening. An unplanned natural experiment: probiotics prevent necrotizing enterocolitis. A single center quality improvement report. So basically, their baseline NEC rate prior to probiotics in 2018 was 4.6%. They then implemented probiotics and a multi-strain with bifidobacterium in, and their NEC rate post that was 0.6%, and that was maintained for 3 or 4 years. They then had the FDA warning. They completely stopped all their probiotics, and their rate has increased now to 3.8%. So not high science, but it's the first bit of data that we've seen coming out from this sort of unplanned natural experiment. So you've got to have a guideline if you want to give probiotics, and I will just give you at the end in my last slide just some my thoughts. So if you're going to use probiotics, use a combination. Lactobacillus and bifidobacterium are good. Make sure you've got two or three species in there too. You can choose all your babies less than 34 weeks, like many of the UK do, or you can choose less than 32 weeks, birth weight less than 1,500, and who have commenced enteral feeds too. And you can give them 0.1 ml twice daily or 0.2 ml once daily. It's full dose is about 5 or 6 drops too. And if you're going to give them, to administer them directly into the mouth, they stick on the sides of the tubes too. And always you need a guideline, you need indications when to stop. So if your baby's been milk per os for about 3 days or more, I would ongoing diarrhea, and then obviously if there's a positive blood culture that contains the probiotic strains. So in conclusion, recent evidence supports a beneficial role for probiotics in preterm infants, particularly for NEC, and that is a lot stronger than what's come out from the Cochrane just 2 or 3 years ago. Strain specificity and early initiation may optimize benefits, so choose your strain carefully and start early too. There is still safety concerns in the babies less than 1,000 grams. And as always, more rigorous trials and real-world implementation data, the VON data, I think is going to be very important in this, and standardization of protocols are needed. So if you are considering using probiotics, or you are, just use them within a risk-benefit framework, understand what that means. And I mean, it's a lot of extra work that's being done. You handling babies a lot more. There's a lot of those issues too. Also look at your local population data. I mean, I know of small units in South Africa who haven't seen NEC for 10 years. So think of your number needed to treat and think about that too. Look at as you said, look at your NEC rates too. And then also very important for some of us, look at its resources. The strains that are some of these are very, very expensive. They're difficult to get hold of. A lot of the big companies don't want to get involved, particularly following the FDA situations, and the fact that there are issues around that. And so those issues too that people should be considering. Thank you.
Thank you so much, Mike. That was absolutely mind-blowing and great. I'm now going to hand over to Shakti, who's going to do a case study. And there's a lot of questions that I think will be addressed by this case study. We are also going to ask you some questions. So please have your phone close by so that you can also answer, and we can just get an idea of what the general opinion is out there. Thank you, Shakti.
Okay, thanks. Thanks, Marty. So good evening, everyone. We actually have 2 cases prepared, but if we can't get through the second one, we'll just start off with case 1. And as Marty said, for the first case, we will need some audience interaction, so please keep an eye out for the poll that will appear on your screen. Okay, so for case 1, you are called to review a day 7, 28-week premature male baby with a birth weight of 1,100 grams and a current weight of 1,000 grams on CPAP for resolving hyaline membrane disease. The nursing team reports several small, non-bowel stained milky vomits. The baby is on full 2-hourly bolus enteral feeds at 160 ml per kg per day via an orogastric tube, receiving fortified expressed breast milk. Multivitamins have been initiated in line with unit protocol. And clinically, the baby is well. His heart rate is 130 beats per minute with a stable trend. His abdomen is soft and non-distended with normal bowel sounds, and the orogastric tube is confirmed to be correctly positioned. So we now just ask you to please refer to the questions on your screen to submit individual responses. Marty will facilitate the poll and will share the results once a sufficient number of participants have responded. There are 4 very short questions and the poll's completely anonymous. I'm just going to flick back so you can see the vignette. But for your first question, based on the clinical presentation, what would your approach to feeding in this baby be? Okay, so okay, I think we're still getting some responses.
Okay, yes, so I'm going to end it soon and share the results. So we've got about 180 people that's participated. I'm going to end the poll and then share the results. So off you go. So Shakti, I'm not sure if you can see it.
I can. So most people, so out of 192 responses, 122 have said they'll continue at the current volume. Okay, so that's good. So just to say that we're not going to give you a correct answer here. The intention is just to explore the range of responses across the participants and to guide the discussion around the case. So Marty, so that looks like yeah, 122. So we can go on to the next one. So most people said they'll continue at the current volume.
Do you want me to ask the breast fortifier next, or the breast fortifier?
Yeah, you can do anyone next, yeah.
Good. You guys can now answer the next one. So would you continue the breast milk fortifier? Okay, great. We've got about 180 people again. I'm going to end and then just share the results and you can just talk through that chat.
Okay, cool. So actually, most people, so 151 out of 208 said that they would. Actually, 57 said they wouldn't. Okay, we'll be addressing that when we talk about the case. So Marty, do you want to go into the question about the multivitamins?
Okay, the multivitamin.
Okay, would you, so just please answer, would you continue the multivitamins? Okay, lots of yeses, it's good.
Okay, brilliant. So we've got about almost 250 responses. I'm going to end it and you can just talk them through.
Okay, again, it's about 187 out of 222. So most people said yes. Okay. And then your last question. So you can, Marty, I suppose we can end that and then go to the last one.
Let me just quickly do that. Why do you not want to? Sorry, the feeding method.
Okay.
Oh, sorry, I'm struggling to share that one. Sorry, doesn't want to work. Okay, I'm gonna have to stop it there and then we'll just.
Okay, I stopped it on my side. Can you try now or still not?
I can. Good.
Okay.
Okay.
Cool. Okay, so for the last one, what changes, if any, would you make to the feeding method? No change, that you'd continue 2-hourly bolus feeds. Would you switch to continuous feeds, or would you withhold enteral feeds completely? Okay, so most people said that they'll continue 2-hourly bolus. And there's a few people that said they'd switch to continuous.
Okay, I'm going to end it.
Okay, that's fine. Okay, thanks, Marty. So the majority of people have said that there'll be no change and they'll continue 2-hourly bolus. And 3 people said that they wouldn't feed the baby, and about 50 out of 200 said they'd switch to continuous feeds. Okay, so I think that's good to get an idea of what people would do, and then we can actually go on now to just look at the case and unpack it a bit more. Marty, so I'm just gonna, okay.
You can just
and yeah, that's fine. Okay. Okay, great. So thanks for the responses. So let us move to a more structured interpretation of the case. So the overall clinical picture in this baby is reassuring. The vomits are non-bowel stained, the baby's vital signs are stable, and an examination of the abdomen shows it to be soft, non-distended with normal bowel sounds. The heart rate trend is a sensitive marker of underlying pathology, and its stability in this case is further support of a benign process. So with that in mind, we can now consider the underlying etiology. Non-bowel stained milky vomits are a normal consequence of gastrointestinal immaturity in preterm babies. They reflect transient esophageal gastric incoordination and delayed gastric emptying, not pathology, and should be interpreted within the broader clinical context rather than in isolation. In the absence of red flags such as bowel stain vomiting, abdominal distension, or hemodynamic instability, there is no physiological or evidence-based justification for reducing feed volumes, modifying the feeding method, or interrupting enteral progression. Reactive reductions in feeding volume or frequency are not benign. They disrupt enteral advancement, they delay attainment of full feeds, impair growth trajectories, increase risk of nutritional deficits, and exposure to invasive interventions such as parental nutrition with their own risks. There is no rationale for intermediate or partial adjustments such as marginal feed reductions or withholding fortifier or multivitamins. Similarly, routinely measuring gastric aspirates as a basis for adjusting feeds should not be practiced. These actions often arise from the urge to do something, yet they are not evidence-based nor offer clinical benefit and risk disrupting optimal nutrition at a critical stage of growth. So trust your examination findings and apply a clear threshold for risk. The baby is either well or unwell, and current evidence supports continuation of full enteral feeds in clinically well preterm babies with no indication for any investigations or imaging. And just before we conclude with this case, I just want, but Trudy covered this very nicely in her presentation, but some people from the audience did choose continuous. So just a short note on that. As Trudy had said, the current evidence is insufficient to recommend one feeding method over another. But what is most important is consistency. So it is acceptable in this context to transition to continuous feeds, but only within units that have the capacity to deliver it safely. It is also equally acceptable to continue with bolus feeds. In the absence of strong evidence, protocol-driven standardized feeding practice is essential to mitigate risk. So each unit should have a protocol for when to transition from bolus to continuous rather than relying on individual preference. Marty, how are we doing on time or the rest of the panel? Because we do have a second case to just contrast the first one. Or does the panel want to just respond to any questions in the chat?
I think you can quickly do the second case and then we'll go to the questions.
Okay, so the second case that we have, we've prepared a very different clinical picture. So this is a day 10, 29-week preterm baby who had been tolerating full bolus feeds, but now presents with bowel stain vomiting, a tachycardia, abdominal distension, and a tender abdomen with reduced bowel sounds. The baby is pink and hemodynamically stable with good perfusion. Despite cardiovascular stability, these findings represent an unwell baby with clear red flags that raise concern for abdominal pathology, most likely an evolving NEC. This is no longer a benign feeding issue related to immaturity. And in this baby, management must be prompt, structured, and protocol-driven. Resuscitate and stabilize as indicated. Stop all enteral feeds and place the orogastric tube on free drainage for gastric decompression. Initiate intravenous fluids as appropriate for the baby's weight and gestational age. Perform a septic workup and initiate broad-spectrum antibiotics within the golden hour, guided by local antimicrobial sensitivity patterns. Once you have confirmed hemodynamic stability, commence parental nutrition. Peripheral TPN is acceptable and safe in the short term, provided good peripheral access is secured. Ongoing care requires minimal handling and close monitoring in a high-intensity care environment. Abdominal imaging is essential to delineate disease severity and identify a possible underlying etiology. And early surgical consultation is important. Perforation should not be the trigger for referral. So these are the two cases that we wanted to discuss. So thanks, and I hope that these contrasting scenarios have helped reinforce a structured, evidence-aligned approach, as all the speakers today alluded to when feeding preterm babies.